We looked at the issue of cognitive dysfunction within our clinical trial program. And just to kind of take a step back, the initial issue with that came from an FDA report, I believe in 2012, that noted that there were anecdotal reports of patients that had neurocognitive problems like memory loss, amnesia, confusion, stuff like that on statins. And so it raised an awareness of it. And so we looked within our clinical trial program because of that and looked very carefully using patient-reported terms, so what they call adverse events, and just looked at a very broad set of groups. And in general, the number of events is very, very small within our clinical trial program. The clinical trial program had over 6,000 patients. We had a handful of events. The majority were mild or moderate in severity. A lot of them resolved while patients remained on treatment, and there was no correlation with low LDL. So in our current cardiovascular outcomes trial, 4A, which is a 27,500 patient cardiovascular outcomes trial in patients that have coronary artery disease, cerebrovascular disease, and peripheral arterial disease, so clinically evident cardiovascular disease, we have a sub-study called Ebbinghaus, named after the scientist that discovered or described the learning curve. And so Ebbinghaus is actually measuring neurocognitive function in about 2,000 patients from 4A using a validated measure of cognitive function. And so we'll be able to address it very rigorously through that clinical trial. In our label right now, it says for neurocognitive dysfunction, and that's that grab bag of terms that include things like confusion and memory impairment, that the incidence was very low. It's 0.2%, either in Repatha-treated subjects or placebo-treated subjects. So the question that was debated, and it's been debated in the medical community, was whether a novel lipid-lowering agent should be approved based on LDL alone versus waiting for cardiovascular outcomes. And it's a valid scientific question. I think the issue that we have is for the patients that we're talking about, and that's patients with very high LDLs and patients with very high cardiovascular risk who don't have any other options, it seemed prudent to offer them this population an alternative until the cardiovascular outcome studies are available. That being said, we also understand how important those cardiovascular outcome studies are, and that's why Amgen and its academic partners have invested a lot of time and commitment to getting that study 4A done as quickly as possible. And so, to that end, we announced in June of this year that we had completed enrollment of that study, and we expect data no later than 2017. We are committed to making sure that we work with payers and healthcare authorities just to make sure that they understand the value of the medicine and that we can ensure that we bring that value to patients, and then also make sure that patients have access. Again, we didn't develop this therapy to keep it kind of in a box and no one getting it. Our goal is to make sure that the right patients get this therapy and that we demonstrate the value and that they have access to it. A monoclonal antibody like Repatha is clearly an injectable therapy, at least for where we are technological-wise at this stage. That's where we are. When we started developing Repatha, we were concerned that a cardiologist, a cardiology community, and even endocrinologists, lipidologists, and eventually primary care doctors aren't necessarily that familiar with injectables. They know insulin, but this is a little bit different than insulin. And so we had some concerns over the acceptability, both from physicians as well as patients. And that being said, we did an open label extension for both our phase 2 and phase 3 studies called OSLER 1 and OSLER 2. And when we planned them, we thought that maybe 30% of the patients would want to stay on a long-term injectable therapy. Well, it turned out that about 80% of the patients that went into those studies decided that they wanted to stay on that therapy. And so we were a little surprised by that in a pleasant way, but I think there will always be a certain activation energy, if you will, that's going to require patients and physicians to adopt this therapy. But again, I think for the patients that we think could benefit the most from this therapy, the view is worth the climb. We think that after Fourier we'll be able to show the clear benefit of lowering LDL with Repatha. The label for Repatha is similar to that of other PCSK9 inhibitors. That being said, there are some differences, particularly around the homozygous FH patient. We also offer 140 milligram every 2 week and a 420 milligram monthly dose, both of which provide that same intensive, predictable LDL reduction. There's still a lot of very interesting scientific questions. I think right now we're very focused on getting our cardiovascular outcome study done. We also have an important intravascular ultrasound study called GLAGOV that should report out next year. We have our cognitive function sub-study, Ebbinghaus. We have another statin intolerance study called GAUS-3 that's using a double-blind placebo re-challenge with atorvastatin, which we think will add to the scientific understanding of statin intolerance, so we think that's going to be very valuable. And then there's a whole wave of other questions that are out there that we're going to work to address with the academic community as we partner together to try to understand more and more about how PCSK9 inhibition can help patients. It's an interesting question. I personally think that there's still opportunities within cholesterol management. Again, I think injectable PCSK9 inhibitors will serve a very important population, and I think really the patients that have the highest unmet medical need. I think that there's opportunities, though, both kind of long-term from a prevention standpoint, but also kind of in a medium term in terms of a therapy that could be used second line that's somewhere between ezetimibe, which is about 15–20% LDL reduction, and Repatha, which is 55 to 75% LDL reduction compared to placebo.